Good evening, good evening. It's Q&A Wednesday, but actually Thursday night. Thanks so much for joining us. Dr. T here. It is a howling Thursday rainy evening here in Perth, so winter is well and truly kicking in. And apologies for running a little bit late tonight, just doing the mummy juggle thing. So thank you so much for jumping on. I really appreciate the fact that you are. Tonight, I want to talk a little bit about the endometrium. This call just coming in. Hopefully I can go back and get that call afterwards. Okay, so talking to you about the endometrium tonight. I have always said to my patients that we know more about the universe and outer space than we actually know about the endometrium. And I still really believe that to be true. I remember when I was first coming into this field of infertility, and I went to this amazing conference over in Sydney. I'm pretty sure it was 2012, if I've got the year right. So what, we're coming up 10 years. And back then, the endometrium was the thing. Everyone was researching how we can improve the endometrium. And I've got to tell you that there's a lot of things that we're still trying to find out about the endometrium, nearly 10 years, 9 years later. So I think this is an area that attracts a lot of attention. I think it's an area that we need to try and understand more. And so a lot of things that I want to talk about, I don't think there's any clear answers. And if you speak to lots of different people, they might have different opinions. But I have had some really great questions. So I thought I'd just discuss a few of them. One question that a few people have asked is the endometrial thickness at the time of doing an embryo transfer. And so I do want to address this elephant in the room, because although it is such this number that we're aiming for, the thickness of the lining, it's actually more than that. So there's lots of things to think about when we're measuring the endometrium. We've got to consider the different technical skill of the person measuring it. We've got to consider the machinery that's being used, the fact that there are what we call inter-tester variability, so differences in technique from one person to the next. We've got to consider that it's quite a gross way of determining if the endometrium is appropriate to put an embryo into. But it's also not about the thickness by itself. It's also actually about the appearance of the endometrium as well. And we want it to have what we call a trilaminar appearance. So to have sort of three distinct layers. So it's about the thickness, but it's also about the appearance of the endometrium. And not a lot of people take that into consideration when they're just grossly measuring across the thickness of the lining. But if we were to just consider that as our gross measure that we use, a lot of the research points to this threshold of 7 millimeters. And somebody actually specifically asked the question, why are we goaling ourselves to 7 millimeters? What is it about that? Well, a lot of the studies that have been done show that the pregnancy rates are better if you have an endometrial thickness above 7 millimeters. In fact, an optimal thickness of about 7.4 millimeters. Now, 0.4 of a millimeter, can you imagine putting your calipers across that on an ultrasound, just how tiny an increment that is, and how you might just move your calipers a little bit. So you start to see that it is quite a gross measure that we're using to assess it. But the studies do suggest that if you have an endometrial thickness that is above 7 millimeters, you have a better pregnancy rate. Now, there is also an upper limit of that, because the upper limit of about 14 millimeters, everything above that, the pregnancy rates start to go down. And that could be because there is some pathology that is thought to be causing an endometrium to get that thick. It might be an overgrowth, perhaps in someone who has really long cycles. It might be that there's actually a polyp present in the endometrium that hasn't been picked up and is being measured as thickness, but in fact is a polyp, which compromises pregnancy rates. So this range between sort of 7 to 14 is thought to be the perfect range, but even closer to that, about 7.4 millimeters. Now, something that I learned, and it wasn't too long ago actually, that you should not really be measuring the endometrium after ovulation when there's been progesterone exposure, because it actually causes the endometrium to compress. So the measurements are not quite accurate. So really, we're looking at endometrial thickness just prior to ovulation, or just prior to a trigger is the best time to be looking at it, and that appearance of a trilaminar appearance. So ideally, if we're using these parameters, a trilaminar appearance to the endometrium with an endometrial thickness of about 7.4 millimeters seems to yield the best pregnancy rates. Can you get pregnant on an endometrium under 7 millimeters? Yes, of course you can, but the prognosis for pregnancies down below 7 millimeters, down particularly below 6 millimeters in thickness, is very poor. And you've got to think about how an endometrium that is not growing up to its potential is then going to affect placentation or development of the placenta, the growth of the baby, and it's not an unheard of situation where a thin endometrium is associated with growth restriction and even preterm birth. So endometrial thickness is important, but it's also taking into consideration that parameters we use are quite gross measures, and perhaps there's other things about the endometrium that is actually really more important. Some people have asked about, and this is my favorite, this is my topic of the moment, is the endometrial microbiome. So a few people actually have asked about the endometrial microbiome and even chronic endometritis. So this is what I know. This is truly pioneering science. We are still trying to understand the microbiome and its impact on health and well-being from a general health. I think the most we probably understand about the microbiome is to do with gut health. But as far as the microbiome of the reproductive tract goes, well, that's an even more difficult thing. But what we know is that the microbiome, or the bacterial makeup of the vagina, is very different to that in the cervix, is very different to that in the lining itself. And this is like the next level, the microbiome actually changes throughout the cycle. So the microbiome in the endometrium, in the follicular, in the front half of the cycle before you ovulate, is very different to the back half of the cycle. And we think that the microbiome varies in this window of implantation, because implantation is from day 6 to day 10 post ovulation. And so we've got this window, and so there's some belief that there is this variation in the microbiome during this. Asha, I would definitely discuss that with your fertility doctor, because it may be a problem, but I can't answer that specifically because I don't know your situation, but I would definitely recommend that you have a chat to your doctor about it. Microbiome, yeah. So, and we don't truly understand the signature of the microbiome. There's also the thought that there are certain disease processes that impact on the difference in the microbiome. So the microbiome of a woman with endometriosis is also thought to be different to that of a woman without endometriosis. The microbiome of a woman with recurrent miscarriage is thought to be very different from the microbiome of a woman who is normally fertile. So there is research going on around the world right now, and even here in Western Australia, looking at this microbiome and how it actually impacts on fertility, and how it impacts on recurrent miscarriage, even how it impacts on preterm birth. So I think it's a little early to say, but I don't know that testing the microbiome in the vagina is actually reflective of the uterus. So it is early days, and there are tests that have been developed and are being utilized out there. One of those is the EMA test. It's part of an endometrial receptivity assay that you may have just discussed it with your doctor, which can actually characterize your signature microbiome in the endometrium at the time of implantation. And there are some databases that suggest that we want a predominance of lactobacilli in the endometrium at the time of implantation. Which particular strain, again, we're not entirely sure, but certainly having a predominance of lactobacilli. So how do you get lactobacilli into the endometrium? Well, again, this is really difficult because we don't have any sort of little concoctions and cocktails that we can inject into the endometrium as yet. And so we attempt to treat the other microbiomes, perhaps treating the gastrointestinal microbiome with probiotics. Again, which probiotic to consume? It would be better to ask our naturopathic or even nutritionist colleagues as to the best probiotics to optimize our lactobacilli. There are some vaginal preparations, pessaries, for example, that can be compounded that contain an optimal amount of lactobacilli, utilizing a lactulose-containing solution to feed the natural microbiome to optimize lactobacilli is thought to be a methodology. A lot of this stuff is in the preliminary stages of research, but certainly trying to optimize that good bacteria to promote that ideal environment which predominates in lactobacilli is really important. What about this chronic endometritis thing? Well, endometritis is an inflammation in the endometrium, and most women who have endometritis are symptomatic. They might have crampy pain, they might have abnormal bleeding, they might even feel systemically unwell. But some women with a chronic, almost like a colonization of bacteria, might not be symptomatic at all, and yet at the micro level they have inflammatory mechanisms happening that causes a very rather toxic environment in the endometrium. And here's the amazing thing, is that if we were to take a sample of the endometrium and send it away for culture, up to 40% of bacteria cannot be cultured. The only way that we can know that it's actually there is to check for its DNA, check for its genomic signature that is different to our own. And so there is a test called the ALICE test, which is able to do that, actually detect the genetics, the DNA of bacteria that cannot be cultured on a standard culture. And again, that's taking a sample of the lining and sending it away for genetic analysis, and then in a directed way actually treating for that specific type of bacteria. And again, these tests are part of the endometrial receptivity assays. Are these robust tests? No. Are these tests that everybody should be doing? No. Definitely, though, the people who are having issues with recurrent implantation failure or recurrent pregnancy loss, certainly this is a discussion to be having around the endometrial receptivity. And this is an area I'm fascinated with, because you watch this space over the next few years, I think we're going to have some really robust evidence coming out around assessment of the endometrium. How dynamic do I think the microbiome is? Sally, I think it's really dynamic, and I think it is really important to try and figure out the signature of this an individual's personalized window of implantation. So I think from cycle to cycle there may be some similarity. We're still finding out things about that. Is one cycle different to the other? So it is really early days. Do we hang our hat on these tests and say they are, the key thing? No, we have to take them with a grain of salt, but we also have to put them in the clinical context of the individual. What else? There's some great questions. I'm so grateful for everybody asking these questions. Oh, wow. This is a really difficult one. Someone's asked a question about going and searching for endometriosis in the context of recurrent implantation failure as an impact on the endometrium. And I'll be honest and say that if you asked half a dozen or more different fertility doctors, I am quite certain that you will get a different answer. So I don't think there is one set treatment pathway here that is right or wrong. What I do know, though, is that women with endometriosis, their endometrium is different to women without endometriosis. And we know that women with endometriosis do have an even more challenging time, even with fertility treatment because of endometrial receptivity issues. There is an understanding that the progesterone receptors in the endometrium of women with endometriosis are not quite normal. It's probably the reason why they have this ectopic growth of this tissue that shouldn't be there in the pelvis. And so there is a belief that women with endometriosis, even if the endo has been treated, still have an endometrial receptivity issue around their progesterone receptors. And often we'll throw bucket loads of progesterone at the endometrium, and a woman, despite being on supplementation, will still shed their lining before they get their pregnancy test. And it's because of this endometrial receptivity. Again, I wish I had all the answers to this, but that's why there are these multi-million-dollar projects that are going on looking at this really complex disease process. So I don't necessarily think there's any number of implantation failures that should be considered or as the time in which you'll go and do a laparoscopy looking for endometriosis. If there is a suspicion of endometriosis, you can go and look for it and diagnose it. But probably my plan, it might be different to others, my plan would be more around medically suppressing the disease as much as possible to improve that endometrial receptivity before putting an embryo back. Others may choose to surgically remove it as their management of suppression of the disease load. But either way, it's important to consider that the endometrium needs to be a focus of treatment in the context of endometriosis because of its impact on receptivity. So again, another huge controversial area. What else? I think I've answered most of them. I think I've talked about thickness of the lining. I think I've talked about, someone has asked me, and this is an awesome question. Thank you for asking it. Yet another difficult area is the thin endometrium. What are the causes of a thin endometrium? Well, I'm stumped as to where to start. Sometimes an endometrium is thin congenitally, meaning that no matter how many, and the hormone that thickens up the lining is estrogen. So no matter how much estrogen we throw at the lining, we just can't thicken it up. And we try and improve the blood flow by using drugs like Viagra. We try and improve the oxidative stress load by vitamin C and vitamin E. We try to use estrogen via a patch to give it in a different way. We superdose with high dose of oral progesterone, and still the lining won't thicken up. It may be a problem with the estrogen receptors in the endometrium. So some women have this like congenitally thin endometrium that we just can't thicken up. And as I've said before, having a really thin endometrium is quite a poor prognosis for fertility and also pregnancy. Sometimes it's because of operations that women have had a D&C, multiple Ds and Cs in the context of infection. Perhaps a cesarean has caused scarring, and scar tissue has developed on the endometrium, and this is called Asherman syndrome. I talked about this several weeks ago, and there's several degrees of Asherman's syndrome that needs to be treated surgically in order to then allow the lining to thicken up again. But thin endometrium is really difficult to treat. There are some novel therapies such as immunological therapies that have been used in experimental situations to thicken up the lining of the womb. There's even a thought that these immunological treatments, GCSF is one of them, actually promotes pro-implantation factors without actually thickening the lining and helps to improve implantation. So it is a really difficult area to treat. It's important to consider that there's not a cause that might be surgical. And yeah, I struggle. I think most clinicians would say that they struggle with thin endometrium. To treat it, it's a really difficult one. And I don't think there's any good research studies out there to prove the perfect protocol to increase the endometrium Plasma-rich protein, PRP, is something that has been suggested as well, but really in the experimental phases so far. So I'm hoping that answers that question, but a really difficult one. I think that's answered all the main questions. What I want to remind everybody is that the things that I've talked about today are very as generic as possible. I try not to target any one specific scenario. All of you out there have your own stories and your own clinical situations, and I must encourage you, if you have any specific questions about you, to go back to your clinician, talk to them, perhaps raise some of these things I might have mentioned, but certainly seek the answers that you find in this. If you've found this really helpful, then please share it with anyone you think that it would be of value to. My desire, my greatest wish is to educate and impart knowledge and to empower you with as much evidence base as I can to help you in your fertility journeys moving forward. So have a beautiful rest of your week. Apologies once again for this being a day late, and I hope you have a beautiful, if not wet, weekend. And to those of you in Perth, hopefully you're getting used to coming out of lockdown, getting used to wearing masks, and you have a great weekend ahead of you. See you soon, everyone.